there's been a huge decrease in hospital-based infections since they started tracking this stuff. Lots of infection reports by nursing homes. That, by the way, nursing home reporting is new in this state. Yeah. What's that? Complications?
No, I'm just being a brag because my capstone is on infection.
Oh, great.
So I'm just laughing.
You know the story.
At the number.
You know the story, right? What do you use for data?
Yes.
Okay, so payment. You're going to start to lose reimbursement for readmissions for hospital-acquired infections. Oh, that's the other one. Nosocomial infections and falls. You're going to lose reimbursement for that's associated with that. And I think all the private insurers are going to start doing that. I ask you, serious question, do you think it's dangerous to withhold reimbursement from hospitals for, let me start with hospital-based infections. Let me restate the question, I guess. You know, for folks involved in health policy, senators, congressmen, right, Barack Obama, Ed Rendell, bless his soul, dearly departed Ed, okay? They think it's fair to not pay you when you have a hospital-based infection.
What about when they screw up?
Sorry?
Can they not get paid when they mess up? I mean,
Well, now that's a fair question, actually. That's more than a fair question.
Sometimes it really isn't the healthcare provider's fault.
Well, that's the first piece. Now, how much, is fault really playing around here anyhow?
No.
Do you think that hospital providers, you, right, nurse practitioners, doctors, and hospitals, want this stuff to happen?
No.
Of course you don't. So this stuff's happening despite your best efforts. True?
Right. In most cases.
Yeah. But nobody sits there and says, I'm going to do wrong site surgery.
No.
I find it the opposite of it. Like for right now, my medical home project,
Yeah.
the hospital, the administration is paying myself and other people to be part of this, mainly because they don't want the readmissions within 30 days.
Okay, fair enough.
So they're not.
Fair enough.
But I guess my argument would be, why didn't they do the right thing to begin with, as opposed to doing it now because it's going to cost
All right,
them.
first, I'll put it back to you as I always do, but
Okay.
I'll overlay something in between.
Okay.
Right? There is a feeling out there that a hospital-based infection, which may cost $50,000 to $200,000 extra in costs, or the readmission, increases the money the hospital gets. There's a political belief on that. And that the hospital is happy to take.
So the hospital would be happy to take the readmissions?
I'm sorry?
The hospital would be happy to take the readmissions?
Correct, because they get paid for it.
The problem is the physicians are happy to take the readmissions.
Because they get paid for it.
Right.
Okay?
Yeah.
Now, the flip side of it is, do you really think they think that way? Even the worst of the CEOs that we've talked about, do you think they really say, I want to increase readmissions to increase how much we get?
No.
No.
I don't even, why do you get the readmissions? There's three kinds of readmissions. Okay? And the most of them, one of the students last year, emergency room, Bill Carbonate, looked at patient readmissions for his capstone. Guess what the big percentage of the readmissions are from?
Infection.
Patients.
Yeah.
Not complying.
Right.
And then there's readmissions for different, unrelated causes, right? Not studied, right? If You know, if a meteor hits somebody, you get readmitted, okay.
I mean, I can see your point there, but then and I know a lot of C-check patients are non-compliant, and so are
Yeah.
COPDs and diabetics.
Diabetics, right?
I don't know, there's still a piece of me that says, you know, if
Okay,
the money was placed, you know, properly to really handle this patient totally,
okay.
then maybe.
Second reason for
That
readmission,
would happen.
right? You got guidelines, protocols, they get people out of the hospital quick because the DRG money ran out.
Right.
APs,
Right.
right? We try to get people out of here. For this condition, we try to have them out of here in 3 days. Right? And if you can keep them in 4 or 5 days, you got to justify it. So instead of trying to go through all the hoops, send them home. Right?
Yeah.
Also, education plays a role. Less than you might think, but it plays a role. Where, you know, a person doing the discharging may not really understand the risk of the readmission. And even though you print out all those instructions to the patients, they may not understand some. Okay? So now, they can pay you and you can do your program and you can reduce readmissions. What proportion of those readmissions do you think you can get?
What proportion?
In other words, of that stuff there, what can you impact it now? Is the question. And if you can impact it, paying you the money to do it will bring a return.
I think we've already showed a small amount, but we have impacted
Okay,
on it.
great project. Keep track of the number of days, we'll do a cost benefit on it.
Okay?
Yeah, great project. Yeah, but the central line infections, we know how to eliminate central line infections. We really do. Now, 5 years ago to have that, well, I think people didn't know. Now, if you don't follow state-of-the-art, central line infection reduction rates, I think it's probably fair not to pay you for that issue. Okay? I mean, the fault cause stuff presumes that you can fix it. If you presume that you can fix it and you can't, now you're just penalizing somebody for something they can't deal with. And that's what I worry about. How about nosocomial infections? Most of them, by the way, come from the outside. They're there on admission.
Well, what they do is they massage the data then, because then they send around this piece
For
of paper
reporting,
and say,
right?
was this really present on admission? Because so-and-so's got pneumonia now and you didn't mention it on admission, so could you please mention that they had pneumonia on admission? So that
I
they
think
don't get
that's a piece.
I have an opposing point of view. I think that there should be some type of negative feedback.
I agree.
Okay.
I agree.
Maybe not like that, but maybe they don't get 100% reimbursement for, if it's a nosocomial.
Oh, I say publish their names.
Or publish the statistics at the hospital.
Uh-huh.
We're already doing that.
Uh-huh.
Okay.
I'll tell you what I'm worried about is if you don't pay people to do the fix, they'll either figure out a way to turf these people or they'll bury the mistakes, is my worry.
Our cardiac surgeon for mentioning the other day in conference said, when their patients go home after, say, a bypass or a valve or something, they step off the curb and they hit with a car within 30 days.
Right.
And they get readmitted. It still comes in as a complication.
See,
within
that
30 days.
should happen.
But it does.
I call that the medium.
It does come in as a complication, as a
Yeah,
readmission.
a complication.
Even if they come in as a trauma because they were stupid and stepped off the curb and got hit with a car, it's a
I'm
readmission
sure
as a
that
complication of their cardiac.
You're not
surgery.
telling me that stupidity is a complication.
Yeah, stupidity, you can't buy stupidity, it's just something in your own.
Being born with it.
Moronic is also.
It does, because it's a 30-day readmission.
Yeah.
And
Yeah.
so there is inherent problems within that.
During Ed Nelson administration, Ann Torregrosa from Philadelphia put together a series of slides, and she concluded that 30% of all healthcare expenditures went to errors and readmissions. Now, that strikes me as not inherently credible, but that's what the governor's office believes at the time. Let's see. Yeah, let's talk about Toyota. Toyota quality control is a lot like Six Sigma. Basically, the process here works around teams, just like you had with Six Sigma. They have these processes called value stream, and they have which is a process of organizing to do safety, reduce errors. Kaizen events, which are sort of week-long events where they focus on problems. And then they have folks who are champions of teams and change agents within an organization. Toyota comes out of automobile manufacturing, obviously. It was originally designed to minimize defects. It's highly process-oriented. And it's got a Japanese flavor, obviously. But it came from here, originally. The basic underpinnings of it are to involve senior leaders in the institution. In healthcare, as it's been implemented, it means that the CEO has to be on board and have buy-in with all of the quality and change efforts. A belief that people can be trained to reduce errors and to be cognizant of higher quality. It's quality in addition to error reduction. Big belief in standardizing processes of care. Did I tell you about the clinic in Canada that does hernia repairs?
Yes.
That's all they do. That's all standard. And they do it the same way.
No.
Yeah, and it comes out of that terminal. Yeah. And the central line infection reduction system, that I'm trying to remember the doctor's name, but that system does exactly that. They have a very standardized procedure. They do it the same way every time. And they train people as a team. Nobody else in the hospital can put it in such a way. You have to be a member of the team. And then they have, it's a patient-centered care model, and they have these events where people come in here like it's like a married patient, where people deal with quality. There's a rah-rah element to it, and yeah, it sounds a little funny, but people get into it. This is, it's the way people work. If you're going to get excited about something, you get excited about patient safety. Why not? Is this all the fad? Remember all the other stuff I showed you from before? For me, it has some troubling similarity to the stuff that's come and gone. A lot of this stuff is not scientific. A whole lot of this stuff is sort of, let's all do this together kinds of things. The PHRI upwards struck me a little bit like that. But the other side of it is, the more attention you give to this, the better, I think. So even if people are doing some things that aren't necessarily scientific, they mean that, at least people are trying to do stuff. Six Sigma, Motorola. Who are you with? Honeywell. Close enough, huh? I think they were doing it with their PV tubes or something when they started. But the idea was to remove errors and minimize variability. Heavy use of statistics with all of this. Yeah. Define sequences of steps and quantifiable targets. Did they teach you about that? Did you have goals
Yes.
for reduction?
I had a mentor that helped me.
Okay.
Really, I went for
Sure.
one of the classes for a week, paid
Right.
for it, was assigned a mentor.
That's the whole process.
They were
Yeah.
even recording me on classes you can go on.
Yeah.
What does being a black belt have to do with this? Is it just the discipline?
No.
It's a learning program.
Yeah. You thought it was for real? Unless you're a karate black belt, you can't do it.
Oh. It's degrees, a level.
I was very impressed.
It's a. It's kind of like, it's more known in the business community, and it's more similar to our board certification.
Yes.
But if you take that, like my husband's in banking, and he's salivating to be black belt certified, he appreciates my green belt more than I do, because he's trying to push his own project through, and it's who's ever favorite pet gets, okay, we'll spend the money for you to become certified, but it's a huge feather in your cap to be.
You have to do a project
It's a
to
project.
be certified.
It's like, almost like a capstone.
Yeah.
If you take that, and it's a project, I worked on it over a year, and then I presented it to all the executives. Part of the whole process was PowerPoint, presentation, everybody graded you. I was really, I mean, it was a huge ordeal, it was a year-long project. Yeah, and it was a week of classroom training, assigned a mentor, a year of working, and then I presented it to all the executives in mine.
Well, I'm even more impressed now that I know what it really is.
No, but it's important to the executives. If you get the black belt, you're on the fast track to senior
Oh, yes,
manager.
you are, yes, you are.
So,
And it's, yeah.
yeah. Six Sigma comes from that error standard 3 per million, which is interesting because I think with some things in healthcare, you'll never get that low. Continuous improvement. Big deal with measurement. Everything gets measured. And so one of the questions is, if you can't measure it, can you do Six Sigma? I don't know. Probably not. It emphasizes commitment of the entire organization. Simplicity and clarity of focus. I mean, did you have to define your project real carefully?
Oh, yes,
And basically data-driven rather than assumption-driven. I kind of like it, actually. It appeals to my statistical side.
Well, my tool was electronic communication. I haven't really thought about that, I kind of probably did that something.
Yeah,
Was that was my capstone?
yeah. Like you said, it was like a capstone, right?
Yeah. Yeah, that's it right there.
In fact, all this comes from Deming, DMAIC, define, measure, analyze, improve, and control. Remember that?
And we use that.
You did too?
Yes, they use it.
Okay. So I got this stuff okay? Define, measure, analyze, design details, and verify design. DMADV. And then root cause analysis. Did you do root cause analysis?
We did fishbone,
Okay. What's a fishbone?
where you identify your problem and you literally lay the backbone of the fish, and then your group process, you identify all the component parts, and then you break into teams, and everybody plays nice in the sandbox, and you come back, and then the bones fall
We all
off.
sing Kumbaya.
We do sing kumbaya.
Yeah. True. I said there's a lot of that in this, right? Define the problem, gather data, ask why it happened. By the way, HSIC8020 and Heritage do this for every Sentinel event. They go through this process, and when they have a Sentinel event, they are required to come to the Patient Safety Committee with this all laid out in a report.
So does the military.
Cool.
Air Force, yeah.
Air Force does it. Identifying causal factors, if you can. But that's good stuff, if you can do it. Multiple causes, pick one.
Yes. Pick what bug you want to work on.
Yeah. Develop a plan for corrective action. Look for solutions that prevent recurrence. Implement action and observe implementation. Lots of types of root cause analysis. Did they ever teach you all these barrier analysis? Very deep.
Yeah, I know nothing about
Bayesian.
Bayesian.
Bayesian is interesting. Did you not study Bayes law and statistics? Oh, it's given a situation, what are the marginal chances of things happening? So errors you may have two states of the world. In one state of the world, errors are much more likely to happen than in other states of the world. So Bayesian says, given a prior which may differ, what are the odds of an error? Bayes' law is very interesting, by the way.
We use Pareto a lot.
Okay, Pareto optimal, right? The best you can get? Yeah. I'm surprised you didn't study this in statistics. Okay. Child abuse, right? The incidence of true child abuse is less than 1 in 100. Okay? So in reports of child abuse, right, the odds of a false positive, somebody reporting child abuse for parents that aren't abusing their children, let's say it's 3%. Okay? So if you get 100 reports of child abuse, you're going to get 3 false positives, right? And maybe 1 false negative. In other words, a failure to report the event because it was rare odds. Okay? But in all, if you have a rare odds event in a population of events that happen a lot, you're going to get a whole lot more false positives than true negatives. In other words, for every person who's really abusing their child, you're going to get 3 or 4 reports of people that are abusing their children in their home.
We've heard horror stories of that happening.
Yeah.
Like a nanny reporting a dime-sized bruise on a orthopedist baby's thigh, and they thought they lost their child.
Yes.
This was in California years ago. And my own children, I mean, they're taught in school, they threaten, we did spank. We had to do SWAT. And my husband accidentally, he was developing and slipped on his hand, and the class thing hit my son's upper butt and bruised him, and my son threatened to report us to CPS. And he did that as a child.
Wow.
I did, well, actually. So, there's just a parent.
She's spanked, I was beaten, so.
But this is reality. Our children are taught about this in school, and my child
Yeah.
actually threatened to you in his anger.
Did you know that this phone was issued Kyle?
Everybody gets beat. And if you don't beat your kid.
What's kept their train on? I remember
No,
that.
but I must say, this was one critical measure.
Okay, last piece of this, right? The concept of optimality. The concept of optimality says there is always, in theory, an optimal level of effort, let's say patient safety, that is going to produce the best results, but it may not be totally 100% error-free. That's what's really behind a lot of this. And I think patient safety folks who are medically trained, not statistically trained, don't quite understand this concept. And it's back to what I said before. Think of the perfectly safe car. Did I do it made for you? Right? A perfectly safe car weighs a lot, goes very slow, right? It's a tank. And it's very expensive. So it costs $5 million. Right? And if you can't afford to drive it, you're out of luck, right? So there probably is no totally safe medical procedure. If you want to know the truth. Stuff happens. Rare odds events happen. Now the question that we need to be asking ourselves is balancing the risks and the costs in terms of what we do. So, first of all, clearly we want to do stuff that has benefit, right? But doesn't have a benefit and has risks you don't want to. But if it has benefits, then you have